I kind of sort of said the outcome. So what is our approach to this population? And again, so we're going to talk about premature infants born at the extreme limits of viability. And I've decided to stop using the word peri-viable because, again, I feel peri-viable is a very negative connotation. And I really want to talk about the limits of viability. And again, this is the set of twins. And I will give you a little bit more detail. I mean, one of them has mild autism, but her older brother, whose term also has it, and her dad has autism too. So is it the 22 weeks? I don't know. Nothing to disclose. So when caring for infants born at 22 to 23 weeks, we want to talk about the importance of culture and philosophy, which we've talked about. We'll spend a lot more time here on management strategies. And I want to talk about how to balance competing outcomes. And you can't balance competing outcomes. You have to decide which is more important. And you'll see I'll say that brain protection is more important than lung protection. Again, we talked about this is hard, difficult, and impossible, but it's really not. And the key is that gigantic team of hundreds of thousands of people for the moon mission. And in the NICU, it's literally hundreds and hundreds of people, if not thousands if you count all the parents that come through that have to work as a team. And we talked about the micro adjustments earlier. I showed you this table, which we would use for counseling, and in terms of giving what we would say the survival is. And we don't try to overwhelm people with very complicated counseling, because that's a trick used by, if you ever bought a new car or a car in person, the salesperson will give you so many choices, your brain will freeze, and you just want to get out of there, so you start agreeing. And that's a known technique to overwhelm people. And the worst thing is to overwhelm a mother who's so stressed. If you try to give more than a couple concepts, their brain will shut down. When they're ready, they'll ask for more details. But we try not to overdo the details, and I do get frustrated. There are some centers that give them all these pictures of a whole bunch of green babies and a whole bunch of red babies, and they all have different proportions. And so I think that's really hard to deal with. Now, this is the IVF twins, and that's them at age 2. I don't know who's a 22 and who's a 23-weeker anymore. I can't tell them apart because I guess they're twins. So let's think about the foundations of mission control. So their motto is achieve through excellence, which I think is a great motto for every NICU, achieve through excellence. And then when I looked at their mission statements, there are 2 things I pulled out that match the NICU completely. One is competence. There being no substitute for total preparation and complete dedication for space, I wrote, or the NICU will not tolerate the careless or indifferent. Now, none of us think we're careless, and none of us think we're indifferent, but it does happen, again, subconsciously when you're dealing with babies at this limits of viability, because it's very easy to say they're too premature. And the AAP will criticize them also, because when you look at the yearly mortality statistics generated by the AAP, a leading cause of mortality is extreme prematurity. As a pediatrician, I can't do anything about extreme prematurity. I can reduce IVH, I can reduce respiratory failure, I can reduce NEC, I can reduce death from septic shock, I can reduce death from congestive heart failure. I can't reduce prematurity. So to me, it's important, if you look at your babies who die at 22 or 23 or 24 weeks, you need to look at the cause of death, and then you figure out what do we need to change. Now, again, you don't think you're careless, but situational awareness is really hard, and especially, again, with this population. And then teamwork, which is really hard. The hardest person to get to be teamwork are the physicians. The attendings are the worst people, because I'm one of them, so I know how we behave. And teamwork is respecting and utilizing the ability of others, realizing we work toward a common goal for success depends on the efforts of all. So the problem is you got some attendings that do not listen to the nurses, do not listen to the fellows, do not listen to the nurse practitioners, do not ever listen to the parents. And if the baby dies, it's too premature, which is a really lousy excuse. And then I took this also, to recognize that the greatest error is not to have tried and failed, but in trying we did not give it our best effort. And again, it's really hard to give your best effort to this population. You're being pushed by people that they want you to get the central line out, that want you to stop the antibiotics. Maybe this, positive blood culture in this population is like 9% of the time. The adults don't even use positive blood cultures anymore. They use sepsis scores based on cardiopulmonary instability. And in adults, and I'm an adult who was septic, You can draw 40 mLs of blood. Positive blood culture is still only 30 to 50% of the time. So I had my 40 mLs drawn, and they're like, well, we're going to continue antibiotics till you're better. We're not going to have a positive blood culture. It looks like on the CT scan that you have like NAC. I'm like, okay, I'm not a preemie, but but if you're saying if my intestinal wall is all infected, sure. The other thing is, if you ever had contrast, it's kind of a interesting experience in terms of global pain when they inject you with a contrast. Okay, so when you're caring for this population, and I would say this is kind of the 22 to 25 week population, you have to have a small baby system. You have to have a dedicated, integrated, standardized structure and culture for extremely premature infants. We published a chapter on that last month. And the system is the star. And the key, everyone thinks, oh, that red person's the staff. No, that's not the neonatologist, that's the baby. And all of us are around the baby. So you got to knock those neonatologists off their pedestal and say, you got to be a team member. You can't be the prima donna. Now, the systems to start, so we do have a separate dedicated unit of 14 beds. We call it Bay 1. All infants under 29 weeks are admitted here, as well as the most critically ill term infants. So it's a small baby unit in the sense that all small babies are admitted there, but we also admit a whole bunch of critically ill term infants, ECMO babies, dialysis babies, diaphragmatic hernia babies, septic shock babies, severe HIE babies, because we want to maintain the expertise of the nurses caring for critically ill infants, regardless of the gestational age. Now, a 28 and 6/7 weeker might be there for 4 hours. A 22 weeker might be there for 8 weeks. So whoever is most stable moves out. It's not based on chronological age or gestational age. We do have a separate nursing staff that it's 50 nurses that primarily staff those 14 beds. It's located right next to our labor and delivery, so babies before 10 minutes of life can be on first intention high frequency. We have a critical care lab just for the NICU, and we have a separate medical team, because it takes just as long to round on 12 to 14 patients in that unit as it does to round on 32 to 36 patients in the step-down unit, or to round on 26 patients in like the level 3 unit. It's a separate attending service, basically neonatal intensivist. About 75% of the faculty attend there, not 100% of the people, because some people just get burned out. And some people just can't triage multiple patients crashing at the same time. There's always fellow, always NNPs. Residents used to be there a lot. Now it's becoming residents. Unfortunately, they're becoming tourists. There's always a dietitian, pharmacist. We have dedicated respiratory therapists. Now, what frustrates me, and I retired before I could yell at the hospital, which I'd like to do, I found out that our dietitian and pharmacist, even though we use more TPN than any other place in our hospital, 800, 900 beds, we only get them 5 days a week. The adult units, the MICU, the SICU, the CVICU, they have a dietitian and pharmacist on around 7 days a week, and we don't. And again, the subtle little things like that shows sort of very disrespect for premature babies, interim babies that are critically ill. Okay, structure. This is an old slide, but it kind of shows, you can see Bay 1 this was 13 beds, there's now 14 beds there, which is right next to labor and delivery. So the idea, after the 5-minute APGAR, these babies are moved back and put on high frequency ventilation. Now, I have this picture because there's some people that do know Steve McElroy. He used to be at Vanderbilt in the past. That's his hand, because when he came, and it's not centimeters, it's inches, but he didn't believe babies this small could survive, so he had to take a picture of his hand with this 22-weeker who is 395 grams. Now, this is just a question, exposure to antenatal steroids and given postnatal life support significantly increased the survival at 22 weeks gestation by how much? And this was a critical paper impacting multiple lives. And the answer is it doubles survival. And so this paper, even though it was written in 2018, was one of the main papers that convinced ACOG to change their approach September of 2021. And I showed this slide, again, that antenatal steroids are critical. You've got to work with maternal fetal medicine. And we know antenatal steroids from 22 to 25 weeks reduces severe morbidities, including IVH, neurodevelopmental impairment, and significant increase of survival, doubled at 22, and at 22 to 23, the network would not, even though we're a member, would not separate out the data. So combining 22 and 23 weekers improved survival by 50%. And it's frustrating to me because I know the authors of the study, no one will break the key on that. And again, I feel that is a bias toward 22-week babies. Now, I showed this slide earlier to show one of the keys at Iowa is that our OBs, they have no reluctance to give antenatal steroids. I've been places where the goal of the OBs is never to give anyone antenatal steroids. But you can see we're close to 95 to 100%. And Vaughan, the mean was 80%, and recently it's got to 90% over 17 years. So it's kind of frustrating. And so when we look at our outcomes in that paper that was published in 2020 by one of our fellows, Patty Watkins, antenatal steroid use was 91% in our inborn cohort. So that's one of the keys. It's very hard to have good outcomes if you have a low antenatal steroid exposure. And what's interesting, this doesn't have to be complete steroids. I mean, you see impact within 12 hours in the RCTs, and there are some unpublished studies that start to see impact on survival within 2 hours. So I never complain, if they can't get the steroid in because the baby comes in and persists, that's okay. And they're okay if they give steroids and the baby doesn't deliver for weeks. Well, one, you don't have a 22-weeker, and they will do a rescue course after 2 weeks. And then this is the table from ACOG. And again, we talked about this earlier, that the key was in September 2021, they switched from not recommended to consider. And a lot of people felt not recommended meant harmful, and it doesn't mean harmful. And I agree with consider because there's no randomized controlled data, because if there was, it would be recommended. But there's enough retrospective and prospective data that's very powerful, replicated numerous times from 2011 to 2022. And again, it has to be considered because you don't want to expose the mom to a drug for the baby or the fetus if the mom doesn't want to resuscitate that baby, or if the if the NICU doesn't want to. The worst thing for an OB is to give moms antenatal steroids and their NICU it's random. Okay, Dr. Smith's on, she'll resuscitate. Dr. Jones is on, he won't. Well, you can't have that variability, and that makes it very hard for the obstetricians. Let's talk about stuff that the NICU can impact. So the first thing is in the delivery room. You have to have an approach to delivery room resuscitation, and it has to be balanced between oxidative injury and mechanical injury. And a lot of people do not focus on mechanical injury, and this is a serious problem. Now, we've always initiated resuscitation with 50% oxygen. Boston Children's has always used 60%. Why the difference? Well, we did 50% because it was halfway between 0 and 100. And Harvard being, smarter, like, well, there's no such thing as 0% oxygen. It's really 21. So halfway between 21 and 100 is 60. Okay. But the whole point is that you have to realize you need, when you have lungs at the canalicular stage, which means you have a huge amount of mesenchyme, you have to create a big gradient to get the oxygen through. You all understand diffusion from chemistry. So you have to have a bigger gradient. So if you want to get oxygen to that capillary that's really far, you have to start with a lot more. If you start with 30%, which is great for a 32-weeker, that actually has a lot of alveolar sacs, but you have no alveolar sacs, basically, it makes life very hard. So we do 50%. We titrate per goals and minimize hypoxia and hyperoxia. Now let's look at some data. Here's a paper. It was a randomized controlled trial from 2017 from Dr. Wee. Babies under 28 weeks. Granted, there were no 22 and 23 weekers in this study. When resuscitated with room air, mortality was 22% versus 6% with 100% oxygen. Now, I'm not saying use 100% oxygen anymore. We used to, back when we didn't know anything. All babies were resuscitated in the 80s on 100% oxygen. Your goal was to have the baby blazingly pink within seconds. We know that wasn't correct, especially at term. But at extreme prematurity, you need to actually start saturating. And so this is something right from the beginning that affects mortality, because that's almost a fourfold difference in mortality based on what oxygen you're resuscitating with on the blender. Now, I'm not saying to use 100% because I know 50% works very effectively. And I know some people are doing some trials with 100%. Now, the next paper that we also then published in 2022 was to look at outcomes. If you don't reach greater or equal to 80% sats by 5 minutes of life, that failure is associated with a greater risk of death or major neurodevelopmental disability by 2 years. So you have to think about that. You know, we need to get to there, and the sooner you get there, the better. You also have to realize that at 22 weeks, you've got to get these babies to transition. You got to be ventilating, getting the CO2 down and getting the oxygen in, because you've got to relax that pulmonary vascular bed. Okay, that's the next step is, what about intubation? Well, you know, you use a 202 for 22 weeks because you don't want to be struggling. I've seen that too many times when people say, well, I just can get this 2.5 in, just give me a couple more attempts and it may tear the trachea. Versus you do 2.0, it's in, it's done. And then 2.0 or 2.5 for 23 weekers, depending on their size. Now, the key thing is, at birth, this is from University of Alabama, published in 2022, invasive compared to non-invasive respiratory support in the delivery room. So electively, pseudo-electively, but automatically intubating 22 and 23 weekers right away, reduced severe IVH and death at 22 to 23 weeks by 2-fold. So I know we're talking about IVH. We already talked about antenatal steroids reducing IVH. And here's the next thing to reduce IVH, not to have these babies struggle to transition and fail before you intubate them. So they're electively intubated, and this was at Alabama, at a place where they really want to work hard on reducing BPD because they want to avoid intubation at all costs. Well, as you go at lower gestational ages, by avoiding them, BPD, you end up having high mortality and high severe IVH. That's a 2-fold reduction in death or severe IVH. You can't use NRP for the ET tube depth. Weight and kilos plus 6 doesn't work. Most of these babies have to be 5.5 to 6. Now, one of the things is we use gentle bagging focused on heart rate and saturations. We're not trying to blow this baby apart. And obviously, where our goal is to be more than 80 by 5 minutes. And we use a PEEP of 5 because it's very easy to get hyperinflated at the canalicular stage. You just don't have that ability of having a lot of alveolar sacs that can handle all this pressure and can distend without rupturing, whereas the terminal bronchioles can't. And now what's interesting, there was a randomized trial. This is a great trial because they disproved something. And it was a sustained inflation trial. And what they found, it was stopped early. There was a significant increase in early death in the sustained inflation group because they're thinking, we got to get the lung open. Open lung, open lung, open lung. Okay. And what happened was death went up to 7.4% versus 1.4% in the controls. Now, this was all the babies, and this is all the babies in that trial. But this 5-fold increase in mortality was in the 23 and 24 week stratum. So 11 out of the 16 cell deaths were in the 23 and 24 weekers. So this is the group, and they, you know, this trial was published, I think, in 2016 and was stopped early, or 2019, I'm sorry, 2019, and was stopped early for the Data Safety Monitoring Committee because these babies could not tolerate this hyperinflation. Basically, they had severe lung damage, and also, don't forget, they were so hyperinflated, there was no cardiac output. So their brains were being highly underperfused. So it's really a strategy, you know, that's IVH supportive. So avoiding hyperinflation. So we don't want to be hyperinflated. We don't want to have mechanical injury. One of the ways to minimize BPD is not to get hyperinflated. You get hyperinflated, you have your RA, right atrium collapses, you have no preload. Your RV collapses, it's hard to get blood flow to the lung because hyperinflated pulmonary vascular resistance goes up, plus your preload is down. Well, there's minimal blood going to the lungs, there's minimal blood draining through the pulmonary veins, minimal blood in left atrium, minimal blood in left ventricle. You remember the Starling curve. So what's your cardiac output to the brain through the carotids? Minimal. So now you're doing something to help the lungs, but it's injuring the brain. So that's another IVH approach. That x-ray is just to show. That was one of the fellows that she told me she never needed x-rays because she always knows where the tube is. And I'm like, well, you don't. And it gets really hard. When you give surfactant to one lung, life is difficult for that patient. I don't want to dwell too much on the 2.0 tubes, but we had published on this because people, one, didn't believe you could ventilate through 2.0 tubes, which you can. the main thing is we know resistance to flow is inversely proportional. So as the radius goes down by the fourth power, it gets harder and harder to get the flow in. So the 2.0 patients did require higher jet PIP, 27 versus 22. So you just have to compensate for that to achieve the same CO2. And of course, the babies with the 2.0 tubes often got upsized. About half of them got upsized to a 2.5 as they grow. But the 2.5 and the 2.0 kids got upsized roughly at the same time, 3 to 4 weeks of life. Mainly the 2.5 kids were getting extubated, and the 2.0 kids needed more time to mature. So the whole thing was, our survival was 77% of patients initially intubated with a 2.0 tube. And these were median birth weight 545, median gestation weight 23 weeks. So the need for a 2.0 ET tube is not a marker of viability. There are people that say, well, we don't want to have 2.0 tubes because if you need it, you can't survive. No, it just means you're small. It doesn't mean you have immature lungs, or I should say non-viable lungs. Now, I will say in this study, the smallest 2.0 patient was 279, and the smallest 2.5 patient was 463. Hopefully, we'll be having a patient going home soon. Mom said I'm allowed to talk about her because she's going home soon, who's 240, and that would be our smallest survivor. Of course, it's a girl. Again, female superiority. That Y chromosome is just a birth defect. Now, we published this paper, and before it even got published, Sweden, Japan, and Germany got hysterical because they're like, we use 2.0 tubes and we don't use the jet, so you're insulting us. I'm like, I didn't do anything. So they wrote a letter and said, look, babies you can ventilate with conventional ventilation and oscillatory ventilation through a 2.0 tube. I'm like, okay, that's fine. We spent all this time getting tons of data and outcomes. So here's something that came from Vaughan. You have to have a golden hour guide. So you have to have standardization of care. And we found that there was too much random behavior back in 2009, and finally got this stabilized so that we did everything the same way. And what matters isn't exactly what the order we do it. It's just that it was done the same way. Didn't depend on which nurse practitioner, which fellow, which staff. And the goals are always the same. We don't want hypothermia. We want to make sure surfactant's in within an hour. Brain protection is dextrose. You don't want to be hypoglycemic. So one of the things is we will get a heel stick gas and glucose pretty quickly if the people are having line issues, because I don't want to wait 90 minutes and find out the glucose is 6. The glucose is 70? Oh, we're fine. Wait for the lines in for the next one. Glucose is 12. Let's put the UVC in a few centimeters. Let's give a bolus. Now we can relax as the brain actually is not seeing glucose. These babies, because I told you choreo's sort of 30 to 60% all get antibiotics started. And the other thing is you have to talk with the mother. I never thought this was important. I'm like, I've talked to the father. And then the nurse will say, go talk to mom. And I tell mom I talked to the dad. And she says, why are you talking to that idiot? I asked him what's going on with the baby, and he says, I don't know. And so these moms, every second to them, they tell me it's like an eternity. So I say someone has to go back, whether if things are under control, I'll go back. If things aren't under control, we'll send someone else back. And we always bring with us, we take a picture just of the baby's face. And even though the eyelids are fused, a close-up of the face looks pretty good. Looks like a sleeping baby, and moms are quite happy having that. And you got to we print it out. In the old days, it was easier with the Polaroid. And you'd put it in their hand, and they often won't let go of it till the next day. And they'll say, no one has talked to me. And I'll come in and say, what are you holding? Oh, a picture of my baby. I don't know how that got there. So that's really important. And I never realized how important it is to talk to the mother. And that's supposed to happen within the hour. And someone can walk over. It's not like you're coding 7 patients simultaneously and no one's available. There's always someone standing around watching. We have lots of order sets. But even with order sets, things can be screwed up. So this thinking that an order set's perfect, someone still can screw it up. So people still need to, check the orders. You just have to double check and you can't always depend on the nursing. Everyone should double check the orders, because we've had problems where a baby passed away because they started too much dextrose. The first glucose was way over 600. Medical issues, there's certain things that we standardize because the literature is so strong about it. One is caffeine. So there's great work by Barbara Schmidt on prevention of BPD. So caffeine, all patients less than 1,250 grams get it. It's automatically written in there as part of the admission order set. Now, in the study, it wasn't like you had to give it at birth, but somehow or other, and they never wrote it like that, but this is therapeutic drift. I wanted it started the first thing the next morning, and now it's like given soon after admission. I don't know if it really matters, but vitamin A, very controversial because it gets hard. Some years you can't get it at all. We will give it if we can get it based on the RCT. If we can't, and we do IM, again, based on the RCT. We have paper guidelines because we have a neonatal reference card. So even though this kind of duplicates kind of what's in the order sets, but it's impossible to read through hundreds of order sets. But this card, which is like 11.5 by 13, double-sided, covers initial fluids, transfusion guidelines, phototherapy guidelines, ventilation goals, ventilator settings, outcome data, feeding guidelines, and dosing guidelines. It's a way to standardize things because you don't want everyone starting phototherapy at a different threshold, everyone transfusing at a different threshold. Now, this is it from like 2014 or something. I recently updated it in 2023, took 3 years off because of the pandemic. And the good thing is, it's been modified, absorbing, the top trial and the European trial in terms of transfusion. The phototherapy guidelines have stayed the same. Everything's designed for neuroprotection. So the phototherapy guidelines are focused on the aggressive phototherapy because that's what reduced severe and profound neurodevelopmental impairment. Some people think that it caused mortality. Well, there was a non-significant trend. How is it possible to survive without a villi? So we were talking about being born at this 22 to 24 week. And you can kind of see, again, that saccular stage, that straight, rigid line of 24 weeks. You have to really draw a bell-shaped curve over that. And I will now say that that bell-shaped curve extends into, the 21 to 3/7 baby did not get steroids. So it extends in there. So it is possible. So again, terminal bronchioles branch to respiratory bronchioles, which branch to alveolar ducts, which terminate the tip into a alveolar sac. You have to have thin wall. It has to be vascularized. Normally, that's at 24 to 27 weeks. This is where our threshold, when I was a fellow, was 24. Importantly, cranial segments mature faster than caudal segments. So you can have areas of the lung mature enough for gas exchange even at 22 weeks. But you need to minimize damage to the lung. So we need these two things. You need antenatal steroids to accelerate lung maturation. Again, it doesn't mean we don't resuscitate if you don't have antenatal steroids. It doubles survival. It doesn't, you still can survive without it. So we're not as rigid as Germany. It will differentiate type 1 cell, which allows gas to go across type 2 cell for surfactant. Importantly, the most amazing thing it does, it thins the mesenchyme so gas exchange can occur, that oxygen can get across, and then it increases invasion of the capillaries and air spaces so that RBC can grab a piece of a molecule of oxygen as it comes through. Now, antenatal steroids also reduce IVH. So again, that's a neuroprotective strategy. And then 2, you need a lung protective strategy to minimize valvular trauma. So our standardization is based on developmental pathophysiology framework. We want to focus on lung protection. We want to reduce the risk of, primarily these days, it's PIE. In the pre-surfactant era, pneumothorax was the main issue. As an intern, some nights I do 9 chest tubes a night. Hardly anyone does chest tubes anymore, but there are a lot of 22-weekers, 23, sometimes 24-weekers that die of PIE. And that's the main problem at the canalicular stage. You don't really get a pneumo. You basically tear the cuff where the terminal bronchiole goes into the alveolar sac off, and you get that mesenchymal air. So at the canalicular stage, usually below 24 to 26 weeks, it's critically important to avoid shear force injury, primarily PA, which is valvular trauma. But I talk about shear force because there are a lot of people think, well, if I volume target convention, I won't be a problem. Well, the problem will be what you set your pressure limit at. If you allow enough, if you keep turning up the ventilator alarms that you're not getting the volume you're guaranteeing, so you keep turning up your pressure limit, you'll get shear force injury. So we're first intention high frequency. We now use the jet for all babies under 27 weeks if they require mechanical ventilation. If the 26-weeker, I guess some more hardy farm stock from mom is, let's say, Amish, and the 2,600 gram IUGR 26-weeker comes out, screaming, he'll go on non-invasive ventilation. I want to back up in time and talk about why PIE is so important to prevent. So PIE is a collection of gases outside conducting gas exchange in airways, which restricts both pulmonary blood flow and ventilation, often develops within 48 hours of life. This is a triplet. The other 2 triplets already died at the other hospital from PIE. They sent this baby to us only because they've been talking nephrology for days about there's no urine, and they want to send this 24-weeker for dialysis. And kind of we got quite upset when we heard about it. I'm like, that's not really the problem. And so we reversed the PIE with the jet. Unfortunately, after a week of, you can see how compressed the heart is. There was no, you think there's no blood flow to the kidneys, there's no blood flow to the brain. So there was overwhelming cystic PVL, and we withdrew support. So unfortunately, none of the 24-week triplets lived in this case. But so PIE has high mortality and morbidity. The sooner you get it, the lower the birth rate, the lower gestational age, everything goes up. And in the pre-surfactant era, where there was good data on this, mortality was above 60% if conventional PEP reached greater than 25 at any time in the first 2 weeks of life for babies under 1,500 grams. So I get nervous when people are setting pressure limits at 25 in order, I think that's actually too high to use. And if someone is needing that much pressure to deliver a set volume, they probably should be on high frequency. Well, they should be on it anyway in the first place. So a ventilator approach for these babies, and I say less than 24, but in reality, I would say 22 to 25. We follow CO2 levels closely with rigid adherence, avoid fluctuations in cerebral blood flow, neuroprotective focus. So we know from work by Jeff Kaiser and others, the lower the CO2 for the longer time, greater the risk of cystic PVL or ischemia reperfusion. The higher the CO2, as you get in the high 50s, 60s, 70s in the first days of life, the greater the risk of severe IVH from too much cerebral blood flow. So one's ischemia reperfusion, one is too much cerebral blood flow. So you have to be neuroprotective. You want to use first intention low tidal volume strategies. Now, whether it's jet or the oscillator. Now, if you do a low tidal volume targeted conventional device, you have to have early rescue with high frequency being available, which is what Sweden does. They do very early rescue. They don't keep turning up the pressure limit. 2O tubes electively. Avoid overdistension. Why is overdistension bad? Well, that's not neuroprotective. Overdistension is just, I've got to have open lung. And you need oversight from experienced faculty because using high-frequency ventilators is not straightforward. And so we want to focus on preventing PIE due to high mortality. I'm going to talk more about extubating when ready for success, not failure, but this is what both Sweden and Japan and us do. You want to have a consistent ventilator and respiratory strategy for all 22-week infants. There should not be random variation depending on the neonatologist. And we target sets based on post-menstrual age to minimize ROP, and that's another. And we use alarm limits for emergencies, not for targeting to avoid alarm fatigue. This is a paper looking at Sweden, Japan, and the US. The key is we all antisteroids, all 2O tubes, all elective intubation in the DR, all focused on neuroprotective strategies. You can see CO2 goals, 37 to 52 in Sweden. We're kind of 45 to 50s. Now, Japan is higher, but they have a much higher incidence of IVH. And their SAT goals are much higher, and they have a much higher incidence of ROP. The anti-value trauma approach, at least for the jet, there's papers showing increased healing of PIE, reduced incidence of air leaks, improved survival in neonates with pneumothorax or PIE, reduced the incidence of BPD in half for infants with RDS treated with surfactant. That's in the 90s by Dr. Kessler. And a paper just published out of Boston, out of Brigham and Women's Hospital in 2024, they compared high-frequency jet first intention to volume targeted ventilation. And so for neonates at high risk, less than or equal to 26 weeks with an OI greater than 5, the jet versus conventional, the infamous 5 per kilo volume guaranteed, the jet significantly reduced the incidence of grade 3 BPD with an odds ratio of 0.21, controlling and adjusting for gestational age, birth weight, and AA gradient. So it's nice to see someone did something that I would never do. Now, it wasn't randomized. It was a quality improvement project to reduce BPD and also reduce their incidence of IVH. So high-frequency ventilation is controversial. It's the carpenter, not the hammer. You have to have expertise in training the carpenters that use them. Without evidence-based physiologic targeted strategies or tools for supporting gas exchange can promote injury instead of improving the quality of lives we save. And that's Reese Clark, one of the first people with the oscillators back in the 90s. So very briefly, I know I'll send a whole bunch of jet guidelines to Scott. But the key thing is to avoid that hyperinflated state, as you can see there, with no cardiac output. So the key thing with the jet is to start at 300, which is a 1 to 9 IE ratio, because at lower rate, more time spent in exhalation, leave the I time fixed at 20 milliseconds, and then you don't get the air trapping because you have to have plenty of time from passive elastic recoil. Especially with a 2.0 tube, you need the extra time. The places that don't do 300, who still do 420 at 22 weeks, the x-rays are horrendous. Everyone has horrible PIE, and I try to tell them just don't do that anymore. Now, the rate will be increased after a few weeks as the lung develops, because a good way to improve both oxygenation and ventilation on the jet, as the lung develops, now you don't need as much time. As the airways get bigger in the lung itself, you don't need as much time. The risk of air trapping is going away, and you want to improve oxygenation and ventilation, so the higher rate will do that. We talked about initial PIP in the low 20s for 2.5, mid to high 20s for 2.0. The initial PEEP is very controversial, but to me it's not. You need to start at 5. Yes, Dr. Kessler's randomized controlled trial was 7 centimeters. That's still too much. And yes, Dr. Wiswell's trial that had a problem started at 5. The 5 wasn't the problem. In Dr. Wiswell's trial, the problem was CO2s in the teens and never touching the PEEP when they needed to. And it was appropriate back in the 90s, early 90s, to use 7 because hardly anyone got anti steroids, and surfactant wasn't very efficacious back then. And so the main thing is just not to get hyperinflated. I misspoke, hyperinflated. Hyperventilation is bad too, but hyperinflation. So this thing of trying to get the open lung right away, we open the lung, we go, gee, the problem is surfactant deficiency, I'm gonna give surfactant. I don't think it's a PEEP deficiency. And this is something I disagree with a lot of people about. I think what you want to do is not destroy the lung from hyperinflation, and you're not giving them volume trauma because you're using the jet, and you want to protect the brain because you just don't want to be hyperinflated and have, as you can see, no preload. So we want to start at 5. We want to avoid mechanical injury to the extremely immature lung from hyperinflation, lung protection. But more importantly, we want to avoid impeding venous return neuroprotective strategy. You've got to avoid impeding venous return, and it's very easy to do with too much pressure. So we'd much rather bring the baby back on 50% oxygen in sets in the 80s than on room air sets in the 90s and hyperinflated and look good for an hour or two and then have horrendous PIE. And then if the baby does make it, oh, look, we got IVH. So our goals on the ventilator is we feel that neuroprotection focus has to outweigh lung protection. All BPD does not correlate to severe neurodevelopmental impairment. Eric Jensen showed what really matters is grade 3 BPD, which is still stuck on the ventilator 36 weeks. That correlates with a 2-fold increase of moderate to severe neurodevelopmental impairment. Not grade 1 or grade 2 for the most part. And what really impacts neurodevelopmental impairment, neurodevelopmental outcome is IVH. So neuroprotection. So the problem is people being aggressively hypercarbic too soon. Yeah, we'll do, once the baby's out of risk of range of IVH, we'll tolerate higher CO2s. But when they can't auto-regulate through blood flow, we'll target pretty tight. So 45 to 55 the first 3 days. Are we gonna freak at 57? No, we're gonna freak at 43 now. At 60, yeah, I'll lose my mind. And anything below 40, I'll be upset. And then we'll slowly, as the brain gets better, slowly tolerate. And sometimes, we'll get gases. The shortest interval will be Q6 if we can't get an ART line, then we'll do Q6. If you have an ART line, we'll get a gas Q3. Okay, and then our saturations are based on post-menstrual age. That's a hour-long talk. We will do repeat surfactant therapy. We know the RCTs, if you give it to everyone on a ventilator, it's not a benefit. But we found 20% of babies do develop post-surfactant slump, which is the lack of endogenous surfactant production. And it usually occurs, as you can see here, after 7 days of life. You can see it's already significant that upper dot is babies with RDS, and it starts to rapidly get worse between day 7 and day 10. And 70% of the babies will improve with treatment. It's actually 63 to 70%. You can predict that if you need 2 doses, it's greater risk of having it. Steroids reduces the risk by 80%. It doesn't matter for endogenous surfactant, lack of, it's either calfactin or prolactin alpha. But at the same time, now we have our hemodynamic service for the last 4 or 5 years, and we can get lots of echoes. It's important if they have a large PDA, you need to also reduce the shunt too. Because if you don't reduce the shunt, you're going to improve compliance and you might cause even worse shunt. So so some patients, you've got to do both. So some patients will start the reduction of the shunt, and we don't even wait for that to be closed. We'll go, gee, their x-ray looks horrible. Let's go ahead and give now some surfactant. But you have to make sure there's not a big PDA. The other thing you have to make sure is that it's not due to sepsis or pneumonia. A lot of times, these babies are usually off antibiotics by between day 7 and day 10. Did they actually have sepsis that was undertreated? Or did they get a congenital pneumonia or something else is going on? So it's one of the things I get upset about. People say, well, we have this baby, and they've got this big PDA, so we're treating this, but he's getting worse, and we can't get blood pressure. But maybe the cuff's broken. I'm like, well, maybe they're septic, And that was, and by the time they told me it was too late, the baby died of sepsis. So don't think the slump is only due to it. Just because you have a huge PDA doesn't mean you also don't have sepsis. And I've told that maybe the PDA reopened because of the cytokines impacting prostaglandin synthesis. Let's talk about another thing is if you fail extubation in the first 2 weeks of life, and you're a preemie, in this case the study was between 24 and 0 and 27 and 6, all these bad things happen when you fail extubation. The only bad thing that doesn't happen is PDA. So when you fail extubation in the first 2 weeks of life, severe IVH goes up, death goes up, BPD actually goes up, and late onset sepsis goes up. So you don't want to push these babies off the vent in the first few weeks. So failed extubation, and the mean gestational age actually is 25.8. So it's actually the less than 26 weekers. And people are like, well, of course, those are the 24 and 25 weekers. And I'm like, then why are you extubating them electively? The smaller babies, then why are you extubating them electively? That's why, you know they're going to fail. And when they fail, death before discharge goes up 5-fold. It goes up, mortality is 28 versus 6%. So extubating a baby in the first 2 weeks of life that's between 22 and 25, you have to be pretty confident they're not going to fail because the outcome of failure is quite horrendous. They also have increased incidence of BPD, so it's actually a strategy to worsen BPD. More late onset sepsis, so it's a strategy that's not consistent with antibiotic stewardship. And if you're reducing severe IVH, it's not a strategy to reduce that by having them fail. And that's after adjusting for all the variables in that paper. Another trial showed failure in the first 12 days of life, again below 26 weeks. Took even at 3 days, they then catch up the vent settings. And another trial looked at failure in the first 8 days. Again, a significant greater risk of death. If you're, again, it was less than 26 weeks. There were no 22 weekers in that trial, and 100% failure rate in 23 weekers. So, you should not be pushing these babies off. And now we also feel the data is very supportive in the literature to use non-invasive ventilation versus, don't put them on CPAP and then wait to fail. Get them on, do non-invasive ventilation, and then they'll succeed. We want to avoid lethal BPD, which is grade 3A. No one talks about this. So you don't want to have death before you even get to 36 weeks from lung disease. So you have a lot of babies dying. You're like, hey, we don't have much BPD because we're looking at, but well, how many die from respiratory failure? We don't know. We don't ever determine a cause of death. Okay, well, that doesn't help. But let's look at Eric Jensen's work. So you want to minimize grade 3 BPD, which is invasive respiratory support at 36 weeks. So if you have grade 3, it's a 2-fold higher rate of late death, serious respiratory morbidity, and moderate to severe NDI. So these babies need to be classified based on that. So his BPD severity definition, grade 1 nasal cannula, less than 2. Grade 2 is high flow nasal cannula, CPAP, or non-invasive ventilation. Grade 3, invasive mechanical ventilation. So for example, grade 3 BPD, 18% required trach versus 0.8% with grade 1 or 2. So for infants born at the canalicular stage of lung development, focus on 21st century clinical definitions of BPD, invasive mechanical ventilation instead of the 20th century definition of supplemental oxygen at 36 weeks, which is a great definition for babies greater than 27 weeks. This is just talking about respiratory outcomes, which I talked about before, that only about 3 out of 195 infants at 22 to 23 weeks with first intentional high frequency require tracheostomy. Gut protection is really critical at 22 and 23 weeks. You've got to minimize the incidence of intestinal perforation, whether it's spontaneous or focal, and NEC. So don't do prophylactic indomethacin. A study out of Nationwide says no benefit of prophylactic indomethacin from 22 to 28 weekers. Avoid indomethacin and steroids. That is a 9-fold increase in perforations. Now, we address our PDA using a targeted echocardiographic hemodynamics approach. So we're very aggressive about screening at 1 day of life, following the PDAs, and if there is a large hemodynamic ischemic shunt that's going on, we will close it. And the most interesting thing about that, if you see this neck, and this is all VLBWs, you can see our neck rate is under 2%, 2018, 2019, 2020, 2021, 2%, 2022 back down to 1%. So this change was due to we don't aggressively feed babies that have reversal of flow and diastole in the descending aorta. We work on getting the shunt closed and just using trophic feeds. Now we do trophic feeds right at birth, 10 per kilo per day. 400 grammer, that's 2 mLs Q12. We beg for maternal breast milk or donor breast milk. We go slowly. Our goal is not to get the central line out quickly. Our goal is to tolerate feeds in a controlled manner without having to get neck. We give our feeds slowly by pump. We used to do probiotics, but that got stopped by the FDA. We look for meconium obstruction of prematurity because there's a lot of this focal intestinal perforation associated with inspissated meconium. So now in Japan, the way they treat it is like 100% of their babies under 24 weeks gets contrast enema. We don't do that. It's about probably 20% of the babies because I don't think our parents would agree to that practice. Standardized TPN strategies. So our priority is to minimize hyperglycemia and hyperlipidemia. None of these are beneficial to you. So we keep glucose 50 to 150. That's neuroprotection. The higher the glucose over 150, what does high glucose do to cerebral blood flow? It decreases it. We follow sodium closely because we don't want to get AKI. We don't want it, and so we don't have that. It does require frequent labs. It does require, we don't use humidity. That's controversial, but we want to accelerate keratinization. So we don't use humidity. It's okay if you want to use humidity. 100% humidity doesn't prevent AKI. There are a lot of places with 100% humidity have sodiums of 167 to 169 because they think I'm 100% humidity, I don't need to get much fluid. Well, that's true. The evaporative loss is gone, but these babies ooze, it doesn't evaporate, it oozes out, and the bed is full of liquid because they have no epithelial layer. So they still lose huge fluid, so you still need to give more fluid than you think. But the skin doesn't keratinize quickly, so I recommend most humidity centers to start with 70% and then follow your protocol, and then you can give more fluid, and you give more fluid as TPN. So we have no problem with giving good nutrition. So total fluids, yes, we may go as high as 250 to 350 after a couple days. The 21-weeker is at 450 for like 12 hours. We always use 3 fluids, UAC fluid, dextrose, but with plenty of acetate to compensate for proximal renal tubular acidosis. So our metabolic acidosis we don't have, so we don't have to hyperventilate anyone. TPN will be 60 to 100 per kilo, so we can make sure we're getting good protein, as well as phosphorus. A lot of these babies are SGA, and they make ATP really quickly, and you can get into arrhythmias from hypophosphatemia, but we don't limit our TPN, and we'll use some D2.5 carrier fluid as another way we need to give a little bit more dextrose. Our initial GIR is often less than 4. If you start at this mystical number of 4, you get hyperglycemic, it's very hard to correct it. And we use a lot of sodium, and then once they're ready for potassium acetate to compensate for renal losses. They often will have, it's much better to have these babies having urine output of 4 to 5 to 6 per kilo than none. Because if they're having none, it's trouble. And they waste a lot of the sodium. Their fractional excretion of sodium is 13 to 15%. So you'll need to watch that and then adjust for that. Intralipids, you don't want to start before 12 hours of life. There was a randomized controlled trial in the early 90s that doubled mortality, starting 1.5 grams per kilo of intralipids at birth. It went from 24 to 48%. So But again, we want to minimize TPN cholestasis, so we never exceed 2 grams per kilo. We just use intralipids. Our goal is we have starter TPN, and we try to give 1.5 grams per kilo at birth. Now, there's a lot of data from late 80s and early 90s, so as long as you're giving at least 2 to 2.5 grams per kilo of protein, you don't get catabolic if you're on 25 to 35 calories per kilo. These babies don't need that much glucose, carbohydrate initially. Their brains are smooth, they're not consuming much. You're supporting all their respiratory drive. There's no reason to arbitrarily say, well, they have to be on 65 to 80 calories per kilo. That's not what they're designed for. They will tell you. You'll see, I'm on 35 calories per kilo. Oh, the glucose is 145. They're not ready yet. The next day, oh, glucose is 115. Okay, let's go up on the GIR now. We also have photoprotector TPN. There's a lot of literature showing that improves survival rate, and that comes out of Montreal. So skincare. So briefly, we use a silicone polymer, and we also use, which is Sween 24, and we use Mepitel, and that combination works really well. We don't use chlorhexidine on the skin because a lot of the babies get burns with chlorhexidine, but we do use chlorhexidine on lines and wires. Blood pressure. You can have numerous conferences for 3 days on this. If you look at the EpiPage 2 cohort study, treated infants who have this isolated hypotension, not septic shock, treated infants who have hypotension that's below the expected for their gestational age, had higher survival rate without major morbidities, including less severe IVH. So if you're trying to reduce severe IVH, you can't tolerate it isolated hypotension. How do we define that? Well, in this study, basically mean blood pressure below the classic thing, gestational age, which my boss hates, but we pay more attention now to systolic blood pressure because systolic is a much better marker of left ventricular output, and especially if the baby has an open PDA. So rather than focusing on mean, we look at both. So if the systolic is at least in the 30s, we're okay. But if it's not, we're going to treat. We will use stress dose hydrocortisone. We actually have protocols now for that automatically wean. And so does Japan, hydrocortisone. That's our first vasopressor. We'll give a little bit of fluid, but usually fluid is not really the problem. Now, some of them also have poor left ventricular function, so they'll get on dobutamine, especially if lactates are rising. So the hope is, even though dobutamine is not really a vasopressor, if you have better cardiac output, hopefully the blood pressure will come up. If you have septic shock, you need a lot of other vasopressors. My boss hates dopamine, so we tend to use norepi and occasionally a little bit of vasopressin, but I don't want to talk about that too much. ID, all our babies, when they're on antibiotics, on prophylactic statin. The other thing we've done is, I was not tolerant. We had 1 or 2 deaths related to Canada. So, Danny Benjamin had a great RCT from 2014 that showed prophylactic fluconazole reduced invasive candidiasis, significant reduction. Now, he wanted to show improved mortality, but invasive candidiasis is not a major cause of mortality in this population. It's respiratory failure. But we wanted to get rid of candidiasis, so we do prophylactic fluconazole. Now, we don't give it for 6 weeks because if the line is ready to come out at day 28, we want it out. So so we give it for at least 2 weeks, and the skin is keratinized. We also screen for IgG. This is for late onset sepsis. So we noticed there was a population that was getting sick at 3, 4, 5, 6 weeks. And then going back to the literature, Carol Baker did this brilliant RCT back in 1992. Now, the interesting thing was the group that benefited, and this was prophylactic IVIG, was the 500 to 750 gram group. Now, we don't do prophylactic IVIG because there's some association with NEC. But when you look in her study, they also measured IgG levels, and all the kids that got sick were under 200. And when we looked at our kids who got late onset sepsis, their IgG levels were less than 40. So what we do is we follow it, and if it drops below 200, they get 1 dose, which usually holds them for the 6 weeks. We do believe that there's an association between when you remove a PICC line and sort of PICC removal sepsis. We found a 12% rate. This was a nurse practitioner project. And once we did that, our use of antibiotics in the whole NICU dropped in half because we stopped having all these kids having these long workups and these long treatments for central line sepsis. From when you remove it, you strip that vegetation. Controversial differences, we do screen again for thyroid function at 1 month of life. About 10% of these babies need are still thyroid deficient, which is seen by their TSH being too high because their thyroid gland is just not responding. They're usually normal by age 3. Some babies you can't get off hydrocortisone, and those are the babies that will try again at 34 to 36 weeks. Inhaled NO, real controversial. Inhaled NO use at 22 weeks is 55%. That's since we've had hemodynamics. So those babies had well-documented pulmonary hypertension. That's from 2018 to 2022. We published on that. And the response rate, 22 and 23 weekers respond better than inhaled NO than term babies. The response rate is 78%. Term babies, it's 40%. So it's just, it's fascinating. If you look at the vascular smooth muscle, a 22-weeker and a 42-weeker are like the same. The best is to be, 38 to 39 weeks and be ready for delivery. Now, we used to use probiotics. That's gone since September 29th. Delayed cord clamping, 48% of the babies at 22 and 23 weeks are vigorous enough that we can do delayed cord clamping. We don't have the ability to ventilate them while they're still attached. So if they're not doing anything, we say give them to us. If they're trying to move and they're taking breaths, we'll do the delayed cord clamping. So you can get about half. We do aggressive phototherapy, which is a neuroprotective strategy because this thing reduces overall NDI as well as profound impairment. And we do targeted echoes. So we start doing echo at usually 18 to 24 hours of life for ventricular function. And then like every other day, and if we have a significant PDA, we'll try acetaminophen. And if that fails after 7 days, we'll do 2 courses of indomethacin. If that fails, they'll either get the piccolo closure, or if they're too small, they'll get ligated. So the conclusion is it's extremely difficult, but not impossible. Okay, thank you.